Hola, yo soy la doctora Fernanda Cheín, soy uróloga oncóloga y el día de hoy estamos aquí con la doctora Laura Mertens, que viene desde Ámsterdam, Holanda, a platicar con nosotros y bueno, nos va a regalar una entrevista, unos pocos minutos, para que nos platique un poco acerca de su práctica y algunos consejos que nos pueda dar para nuestra práctica urológica. So, hello, Laura. It's a pleasure to be here today with you.
Thank you.
And
it's a
to
pleasure.
having you in our Congress. So I would like to make you a few questions about your practice.
Mhm.
So we were talking about that you are a neurologist oncologist,
Yeah.
and like your area of expertise is bladder cancer.
Yeah.
So can you tell us about what you do in your practice, like every day? How many cases do you see in a week of bladder cancer? How many surgeries, and how does your teamwork happens to be?
Yeah, thanks. Thanks for the interview. I work at the Netherlands Cancer Institute in Amsterdam, and that is a specialized oncological hospital where we combine patient care with research. So most of the physicians who work there combine patient care with research.
That's interesting.
So I usually start my week with a day of research, focusing on writing new trial proposals, guiding our PhD fellows. And then regarding clinical practice, we all focus on one or two organs or malignancies, and I indeed focus on bladder cancer and on prostate cancer early diagnosis. So it means that some parts of the week I see patients referred for treatment of bladder cancer. They were usually diagnosed at another hospital, and then sent to us for definitive treatments. So that's second opinion outpatient clinic, bladder cancer surgery, and also some prostate cancer early diagnosis, which means MRI-guided peritoneal biopsies.
Okay, that's so interesting. And how does your practice work? Like it's a private practice or public practice for all the population?
It's public practice. It is a tertiary referral hospital. So in the Netherlands, patients usually go to the GP, to the general practitioner first, and then they are referred to a local hospital where they, for example, in the case of hematuria, perform a
There's a
cystoscopy,
neurologist, a
CT.
general urologist.
Yeah, and they
do the approach.
often do a TRPT there as well. And once, for example, muscle invasion has been found or BCG unresponsive disease, or when a patient wants to be referred to us, we see the patient. So it's a tertiary line, but it's all public. So all healthcare in the Netherlands is public and fully covered by the insurance.
Okay. So that's really interesting. Like you tend to see the most complicated cases, I understand.
Yeah.
As if you are going to see like the muscle invasive bladder cancer and the most advanced disease, right?
Yeah.
So which has been in your practice like one of the most challenging cases that you remember and that you recall right now? And how did you do to solve it? Like you have a tumor board to make the decisions, or how does it work?
I think tumor boards are extremely important, especially in those complicated cases, because you, first of all, you just want to look at a patient with a fresh eye. So you want to revise all the imaging, discuss again in the multidisciplinary team, and then make a treatment plan together with the patient. Often they also have a preference about the treatment.
So they can have like they can have the decision in their hands.
I think the final decision is for the patient, but it's our task, our goal to fully inform the patient. And if there is one preferred treatment option, I think I have to tell them that. Ultimately, the patient decides if he or she wants to go for that treatment or not. But sometimes there is a choice, and I think we also have to inform them about that. And of course,
that's true.
Yeah, there's a couple of patients, especially I remember a young woman, 38, 3 young children, muscle invasive disease, very rapid recurrence after radical cystectomy. And in those kind of situations, this really leaves a lasting impression.
Okay, yeah, that's so true. And it's important to take always the patient's decision in count.
Yeah, and
Right.
to counsel and guide them as good as possible, even in cases of bad news.
Yes, that's really important. And which is the surgery that you most perform? Like in the cystectomy, it's with with some bladder preservation, or a neobladder, or just a radical cystectomy with ileostomy, or
What we try to do in our hospital is open trials on bladder preservation.
okay.
Not because I don't like to do cystectomies, I'm a urologist.
Yeah.
And I like to do this procedure. Also, I'm convinced that we can do it better and better and better, robotically, nerve sparing. But still, patients keep asking for bladder sparing treatments. And I think this must be feasible in this era of novel systemic therapies. So we always aim to offer some sort of bladder sparing option,
Okay.
yeah, or a trial.
Okay, so that's interesting because obviously we like to make surgery, but also the patients like seek to preserve their organs because it's, as we know, a really morbidity. It has a lot of morbidity, the surgery, and also which is the quality of life of patients, right?
Yeah.
So it's important to take into account the bladder preservation and to know that in your center you are trying to do more and more bladder preservation, right?
Yeah, I don't think cystectomy is going to disappear. I don't think bladder preservation will replace it. But patients are asking these kind of questions, and then.
And as all we know, bladder cancer, it's really frequent in Europe, right? So this last year I went to the European Congress in Madrid, and I saw that many of the topics are about bladder cancer, and we also see bladder cancer, but I think that it's more the incidence is greater in Europe than in Latin America, in these countries.
I don't know exactly about the incidence, but I do know that all of a sudden over the past years, the interest in bladder cancer, also scientifically, has rapidly grown.
Yes.
Partly because of the bladder sparing treatments, robot cystectomy, but I think mainly because of the new systemic therapies.
Yes.
Are you going to London, by the way?
Oh,
to the
yeah,
EAU?
no, I can't. But I was looking forward to it. But well, it will be next
time again.
Yes.
Yeah.
Yes. So just to end, like I would like to for you to tell to the young urologist like an advice in our practice, in our daily practice, and also for all the residents that are doing this specialty. What would you like to share with them? Like about the research that you do, we here in Mexico, we all not do research. Mm-hmm. Many of us only focus on the urologist practice. So which will be your advice? Because obviously research is a great area for this group of medicine.
Yeah, I think with research you can really improve things in medicine, in urology, in oncology, urology, and you don't have to take major steps. If you just start with a topic that you like, something simple, then you can already make a difference. And it might not always be fun, but if you just keep going, it'll ultimately have a result and hopefully make you feel happy as well.
Yeah, and as you were telling us, how do you do your practice like one day for research? That's interesting because you are not just focusing on research, you are also doing the practice of urology. So yeah, I think that's a good balance.
Yeah, I love the combination.
Yes. Well, so thank you so much, Dr. Lara, for sharing with us this little interview, and it was great to have you here today.
Thank you very much.
Well, thank you.